1, 2,
and review, female.
Oh shit, I got some blood going. Oh, he's wearing it too.
You're in the bay. Once you get over to the bed, we'll give you the story. Everything's going to happen super fast. Welcome to the emergency room.
I lost the pulse.
It's
300 please.
I'll keep you on guard again.
Pulse check. No pulse.
no more pulse.
Yeah. Here, what are the echo people get? And her blood pressure is off the dropping.
45 minutes of CPR and no return of circulation. Okay.
Usually we talk about a medical diagnosis. There's this this expectation of precision, like engineering.
Right, yeah, like a broken bone.
Exactly. You break your arm, the x-ray shows that jagged white line, and the doctor just points and says, there it is, broken.
It's binary, it's clean. And honestly, I mean, it's comforting. We like things to be visible and easily categorized.
But then you step into the world of respiratory critical care, and suddenly that x-ray machine feels completely inadequate.
Oh, completely.
We're looking at a diagnostic landscape that is just incredibly murky. So in this deep dive, we're getting into the minds of elite ICU intensivists.
Which is a whole different way of thinking.
It really is. Our mission today is aggressively applying the 80-20 rule to respiratory critical care. We're looking at how to navigate that murky landscape when a patient's breathing starts to fail.
Because true critical care, it isn't just reacting to alarms going off. Anyone can hear a beep and look at a monitor. Thinking like an intensivist means understanding the cascading biology behind the failing physiology. It is about anticipating the crash long before the patient actually codes.
Okay, let's unpack this. Our source stack today includes a massive breakdown of respiratory pathophysiology, advanced diagnostics like SCVO2 and ABGs, and a really complex, real-world case study of a patient named FT.
It's a great stack, and it requires a fundamental shift in how you view the body. If we strip it down to the absolute core mission, the 80-20 overview here, the respiratory system is solely concerned with gas exchange.
Not just breathing.
Right. It is not just about moving air in and out of the lungs, which is just ventilation. It's about matching that incoming air with blood flow right at the alveolar-capillary membrane.
I always picture it like a massive biological supply chain. The lungs are the factory workers packing the oxygen boxes on the loading dock, and the cardiovascular system, the heart, is driving the delivery trucks.
I love that analogy. That's the perfusion.
Yeah. If the delivery trucks break down or if the factory workers stop packing, the entire metabolic factory just shuts down.
And mapping out exactly how that factory shuts down is how you save a life. It always starts with a trigger.
Right.
In respiratory failure, that trigger is usually alveolar collapse. Think of atelectasis, where the tiny air sacs just fold in on themselves from a lack of surfactant. Or the trigger is a fluid barrier, like pulmonary edema.
Right, because oxygen is a gas, and it has to diffuse across a membrane. If you flood that membrane with fluid, you've just dramatically increased the distance the oxygen has to travel.
Exactly. It physically can't make the jump into the blood. So that trigger, whether it's collapse or fluid, causes a profound physiologic change. We call it a VQ mismatch.
Ventilation-perfusion mismatch.
Yes. Blood is flowing past alveoli that have no oxygen to give. This leads directly to a decreased PO2 in the arterial blood. But your body doesn't just passively accept this.
No, it fights back.
Right. It enters the compensation phase. You have central chemoreceptors in your brainstem that are exquisitely sensitive to rising hydrogen ions.
Which means they sense the blood becoming acidic from trapped carbon dioxide, right?
Literally hitting the panic button. Meanwhile, you have peripheral chemoreceptors in your carotid bodies sensing the dropping oxygen levels. Together, they trigger a massive sympathetic nervous system response.
So mechanically, that sympathetic response is the body trying to force the supply chain to work harder.
Exactly.
You see tachycardia because the heart is trying to drive those delivery trucks faster. And you see tachypnea, rapid breathing, as the lungs try to furiously pack more boxes.
But there's a biological limit to that hustle, They cannot keep that pace up indefinitely. The respiratory muscles, particularly the diaphragm, require huge amounts of energy to sustain that rapid breathing.
And eventually they just give out.
Right. Those muscles fatigue. And that's where we hit decompensation, which is a terrifying clinical sign.
Because decompensation doesn't look like faster breathing. It looks like the breathing suddenly slowing down.
Yes. The tachypnea gives way to a dropping respiratory rate, not because the patient is getting better, but because they are physically exhausted. That leads to severe hypoxemia. We're talking a PTO2 of less than 40.
Wow, less than 40. That's the threshold where you start seeing the really late dangerous signs, right? Like cyanosis, profound hypotension, and eventually coma.
Because the heart muscle itself is starving for oxygen. The tissue ischemia has become an immediate threat of cardiac arrest.
Which brings up a really crucial distinction in how we monitor these patients. The difference between SpO2 and ScVO2, this blew my mind in the sources.
Oh, that's game-changing.
Because if I look at a standard monitor and see a patient's SpO2 is 95%, my immediate instinct is, great, they're oxygenated, we're good.
Right, but that is the blind spot of the SpO2 monitor. It tells you nothing about tissue consumption. It just tells you what's on the arterial trucks.
Exactly. That is where ScVO2, central venous oxygen saturation, is so incredibly valuable.
It's measured from a central line sitting right in the superior vena cava. It tells you the oxygen saturation of the blood returning to the heart after it has circulated through the upper body.
And a normal ScVO2 is roughly 60 to 80%, right?
Yes. So let's play this out. What's fascinating here is how a dropping ScVO2 warns you that tissue demand is outpacing supply.
So if I see a patient whose ScVO2 is down to like 50%, even if their pulse ox still reads a perfectly fine 95%, what is actually happening at the cellular level?
It means your tissues are starving. They are hoarding every molecule of oxygen they can get their hands on. The oxygen demand is radically outpacing the supply.
So the returning blood is severely depleted.
Right. That dropping number is an early warning siren. It tells you that you have to step in and assess their airway and perfusion immediately.
And the reverse is equally terrifying, right? If you see an abnormally high ScVO2, say it's over 85% in a patient with a severe infection, that's a massive red flag for sepsis.
Yes, because the tissues are so sick, they've lost the ability to even extract the oxygen. The trucks are returning to the factory completely full because no one could unload them.
Wow. So to think like an intensivist here. The problem is hypoxia. The failing physiology is a gas exchange barrier. The immediate threat is tissue ischemia and arrest. The intervention is optimizing O2 delivery, and the reassessment is checking ScVO2 and ABGs.
Exactly.
So if you remember only 5 things from this first part. 1, the core pathophysiology is alveolar collapse or fluid accumulation blocking gas exchange. 2, the key assessment finding is that restlessness and tachypnea are early, while cyanosis and lethargy are late and dangerous.
Extremely dangerous.
3, the most dangerous complication is severe hypoxemia PaO2, less than 40, causing cardiac arrest. 4, your priority nursing action is ensuring airway patency and optimizing O2 delivery. And 5, the most important treatment is supplemental oxygen and treating the underlying cause of the barrier.
Right, so your one-sentence clinical picture is a restless, tachypneic patient pulling at their lines with a dropping ScVO2 despite supplemental O2.
And the golden rule, if you see new onset restlessness and a dropping ScVO2, think oxygen demand is outpacing supply and assess the airway and perfusion immediately. Okay, so let's move from theory to bedside reality. Let's look at FT. He's a 70-year-old male with a 30-pack year smoking history.
A very common presentation.
Yeah. He has COPD and heart failure. And right now, he is sitting on the edge of his bed in the tripod position, severely struggling to breathe.
This is a classic, highly lethal scenario. You have a chronic baseline of lung and heart disease, and now an acute crisis is superimposed on it.
The 80-20 overview for FT is that he caught a viral infection from his granddaughter. That virus is the trigger. And his SpO2 is currently 87% on 3 liters of O2.
Right, so let's look at the pathophysiology. The trigger is the respiratory infection. The physiologic change is massively increased mucus, airway resistance, and bronchoconstriction.
Because he has COPD, his lungs have already lost their elastic recoil. He suffers from air trapping.
Exactly. He can get air in, but he can't get it out. Now add the fluid overload from his heart failure, pushing fluid into the alveoli. It's a profound VQ mismatch.
And his compensation is that tripod position. He's sitting up, leaning forward. By doing that, he physically increases the AP diameter of his chest and uses accessory muscles to force air in and out.
But decompensation is looming. Hypoxemia, dropping SpO2, respiratory muscle fatigue.
Right. In our assessment, the early classic signs are tachypnea, he's breathing 30 times a minute fine, and coarse crackles, expiratory wheezes, and prolonged expiration.
And you have to know when he is deteriorating. The patient is getting worse if his respiratory rate suddenly drops, but he remains in distress, or if he becomes confused or lethargic.
Those are late signs of hypercapnia and hypoxemia. His ABG shows a compensated respiratory alkalosis with hypoxemia. He's hyperventilating to compensate, but he's tiring out.
And then there are his labs.
Yeah, his potassium is critically low at 2.9, and his pulse is 110 and irregular.
This is where you connect the ADPII dots. Assessment. Recognize the tripod positioning and irregular pulse. Diagnosis, impaired gas exchange, and high risk for lethal dysrhythmias.
Because of that low potassium.
Exactly. So for priority nursing actions, first, keep him upright in that tripod position to maximize chest expansion. Next T, optimize O2 delivery. Then, address the potassium of 2.9 and administer bronchodilators and diuretics.
And for escalation, you notify the provider immediately for the K of 2.9 and the irregular pulse. But you call a rapid response if his mental status declines.
Yes. For medications, he gets albuterol, a short-acting bronchodilator to decrease resistance, and furosemide, a diuretic to pull fluid off the lungs. But, and this is key, furosemide likely contributed to that 2.9 potassium.
Right, because loop diuretics waste potassium. So the drug treating his fluid overload is threatening to put his heart into a lethal rhythm.
It's a delicate balance.
So for pattern recognition, if you see crackles +3 plus pitting edema plus a barrel chest, think superimposed heart failure on top of COPD.
Spot on.
Now, I have to ask about an ICU pearl or maybe an exam trap here. FT has COPD. Wait, aren't we supposed to withhold O2 so we don't kill his hypoxic drive to breathe?
I am so glad you brought this up. It's a classic novice trap. Yes, chronic COPD patients lose sensitivity to high CO2, relying on low O2 to breathe, but you never, ever withhold oxygen from a severely hypoxemic patient in acute distress.
Because the hypoxia will kill them faster than the hypoventilation.
Exactly. Fix the hypoxia first to save his brain and heart, then titrate the oxygen later.
Okay, so if you remember only 5 things here. 1, core patho is air trapping from COPD plus fluid overload from HF equals severe airway resistance and VQ mismatch.
2, key assessment finding is the tripod position, prolonged expiration, and accessory muscle use.
3, most dangerous complication is respiratory muscle fatigue leading to arrest or lethal dysrhythmia from hypokalemia.
4, priority nursing action is elevate the head of the bed, titrate O2, and monitor cardiac rhythm.
And 5, most important treatment, bronchodilators, diuretics, and electrolyte replacement.
So your one-sentence clinical picture is a barrel-chested older adult in a tripod position, breathing 30 times a minute, with crackles, wheezes, and an irregular tachycardia.
And the rule, if you see a tachypneic COPD patient suddenly become lethargic with a dropping respiratory rate, think hypercapnic respiratory failure and prepare for immediate mechanical ventilation.
Absolutely.
Okay, but sometimes medications aren't enough. We have to look inside and mechanically remove the obstacles to gas exchange.
This brings us to high-yield ICU procedures, bronchoscopy and thoracentesis.
The 80-20 on this. Bronchoscopy clears the pipes from the inside. Thoracentesis clears the space around the pipes, the pleural space.
Yeah.
Both are highly testable and highly dangerous if post-op care is missed.
Let's start with bronchoscopy. We put a camera into the airways for a biopsy, lavage, or removing mucus plugs. For nursing prep, the patient must be NPO for 6 to 12 hours and they get sedation.
And the complications are hemorrhage, pneumothorax, or aspiration.
Right. And the cause to finding to action sequence here is crucial. The sedation and local anesthetic paralyze cranial nerves IX and X.
The gag reflex.
Yes. So the finding is an absent gag reflex, the nursing action. Keep them strictly NPO until that gag reflex returns.
Otherwise, they silently aspirate. Now, thoracentesis is a needle into the pleural space to remove fluid. For nursing prep, you position the patient upright with elbows on the overbed table, feet supported.
And you must instruct them not to talk or cough.
Because if they do, the lung expands, hits the needle, and you get the major complication, attention pneumothorax.
Exactly. If we connect this to the bigger picture, both of these procedures instantly improve lung compliance, the ability of the lungs to expand, dropping intrathoracic pressure, and reducing the work of breathing.
But there are ICU pearls and traps here too. A classic novice trap is feeding a patient too early post-bronchoscopy before those cranial nerves have recovered.
Right, causing silent aspiration.
And another trap, assuming asymmetric chest expansion post-thoracentesis is just normal pain splinting when it actually might be a pneumothorax.
That's a massive trap.
So intensivist thinking. Problem is pleural effusion. Failing physiology is compressed alveoli and decreased compliance. Immediate threat is hypoxia. Intervention is thoracentesis, and reassessment is a chest x-ray to rule out pneumothorax and auscultating breath sounds.
Perfect.
So if you remember only 5 things for procedures. 1, core patho is fluid or mucus mechanically blocks lung expansion and gas exchange. 2, key assessment finding is absent breath sounds over the affected area or dullness to percussion.
3, most dangerous complication is iatrogenic pneumothorax or aspiration.
4, priority nursing action is check the gag reflex post-bronchoscopy and auscultate breath sounds post-thoracentesis. And 5, most important treatment is mechanical removal of fluid or obstruction and a post-op chest x-ray.
The one-sentence clinical picture is a post-procedure patient who suddenly develops asymmetric chest expansion, tachypnea, and absent breath sounds on one side.
And the rule: if you see tracheal deviation and absent breath sounds immediately after a thoracentesis, think tension pneumothorax and call for a rapid response in chest tube placement.
Yes, immediately.
So what does this all mean for you? Mastering respiratory critical care means understanding the physiology of gas exchange. It means anticipating decompensation before the patient crashes.
It's treating the underlying cause, not just the alarms.
Exactly. It means utilizing advanced data like CFeVO2 to see if tissues are starving, respecting the danger of electrolyte shifts like FT's low potassium, and vigilantly guarding the airway post-procedure.
And I want to leave you with a final provocative thought.
Go for it.
We talked a lot about baselines today, but aging naturally decreases elastic recoil, decreases functioning alveoli, and lowers baseline PO2. As our population rapidly ages, how will the normal baseline parameters of the ICU have to shift? Will the textbook definitions of hypoxemia and respiratory failure have to be completely rewritten for the geriatric ICU of 2030?
Wow. That is something to really mull over, because if the baseline shifts, that murky diagnostic landscape only gets harder to navigate. Thank you for joining us on this deep dive. Take this intensivist thinking straight to your next shift and keep questioning the alarms. We'll catch you next time.